Good morning and good afternoon, everyone. My name is Jessica Butts, and I'm a health scientist with the President's Malaria Initiative based in Atlanta. I'll be your moderator for today, and I'd like to welcome you to this webinar on improving provider behaviors for malaria. Today, we'll be launching a tool that's the result of a joint collaboration between Breakthrough Action and the PMI Impact Malaria Project, our flagship global social and behavior change and malaria service delivery projects. Breakthrough Action is a 5-year cooperative agreement funded by the United States Agency for International Development, USAID, to lead their SBC programming around the world. Breakthrough Action harnesses the power of communication from mass media to community outreach to user-driven social media campaigns to inspire lasting change while also using innovative approaches from marketing science, behavioral economics, and human-centered design. Similarly, PMI Impact Malaria is the flagship global service delivery project of PMI. The PMI Impact Malaria team works with national malaria programs by strengthening diagnosis, treatment, and drug-based prevention programs for those most at risk, particularly children and pregnant women. Making strides in malaria control requires a strong focus on provider behavior. The Global Malaria Technical Strategy 2016 to 2030 calls for universal coverage of core interventions and improved surveillance. As key influencers in the patient-provider interaction, providers serve as gatekeepers for IPTP, for malaria testing, and for treatment. Providers also influence the quality of routine data, including malaria surveillance and health management information systems data. So we're faced with an important question. What drives provider behavior, and how might we improve it? And what are the innovative and promising approaches that we can use beyond traditional training and supervision? So during this webinar, we'll present a new resource outlining a systematic method for understanding and addressing provider behavior for malaria. And our goal in this webinar is to help listeners understand how to effectively integrate insights and best practices from both behavioral and service delivery perspectives to improve provider behavior and service-related outcomes, particularly around malaria case management, malaria and pregnancy, and data quality too. So I'd like to introduce today's presenters. We'll have Angela Acosta. She's a Senior Program Officer with the Breakthrough Action Project, based at the Johns Hopkins Center for Communication Programs. We'll also have Mary Warsh. She's the Deputy Director for PMI Impact Malaria with Population Services International, PSI. And Keith Esch, he's a Technical Advisor with the PMI Impact Malaria Project as well, also with PSI. In terms of the format for this webinar, we're going to begin with a step-by-step review of the blueprint, and that'll be presented by Angela. And after each step in the blueprint, there's going to be an example provided from the field, and that'll be provided either by Mary, Keith, or Angela. And the presentation will be followed by a question and answer and conclude with some resources. So I wanted to cover a few housekeeping announcements before we begin the webinar. We are recording today's webinar. We'll make that recording along with the slides available after today's session. All participants online are on mute. We've devoted time for questions and discussion in the second half of the webinar. We encourage all of you to submit questions throughout the session using the chat box at the bottom of your screen. And finally, we have a very brief poll, it's only 4 questions long, that will appear on your screen as we close the webinar. So please remember to take just a minute to complete that poll before you sign off. And without further ado, I'd like to introduce to you our first presenter, Angela Acosta. Angela will provide us with a step-by-step overview of the blueprint. Welcome, Angela.
Thank you, Jessie. Good morning and good afternoon, everyone. So why are we focusing on providers? As Jessie noted, providers making strides in malaria control will require a strong focus on provider behavior change. Providers are the gatekeepers for the provision of IPTP, malaria testing and treatment, and because they fill out HMIS forms, they also control the timeliness, completeness, and accuracy of service statistics. Improving provider behavior can reduce barriers to quality service provision, enhance the client experience and increase demand for services, and boost malaria outcomes and improve surveillance. Next slide. In 2018, Breakthrough Action held an expert consultation meeting with malaria partners, including service delivery partners, to identify key areas of future work. One of the main findings was that although providers are gatekeepers for key malaria outcomes, we did not have a systematic way of understanding or addressing provider behavior for malaria. This was paired with a growing interest in finding better and more innovative approaches to provider behavior change. So over the past year, Impact Malaria and Breakthrough Action have been working together to draft a resource document called a Blueprint for Applying Behavioral Insights to Malaria Service Delivery. This document highlights 6 best practices for designing provider behavior change programs for malaria. It brings together a behavioral lens and the service delivery context in a practical how-to format. It encourages a deeper look at the internal, social, and environmental factors that influence providers. And it helps programs pinpoint which factors, behaviors, or providers need to be addressed more precisely in order to obtain the desired results. Next slide. Here are the best practices in the blueprint. I will give you a few seconds to read them out loud. I will also go over them in more detail shortly. These steps may be familiar to most of us. Many of us are practicing them already. What's different is that the blueprint groups these practices together to encourage us to be more methodical and intentional about the way we approach provider behavior change. Next slide. The first best practice is to define the behaviors you wish to change. For many of us, our end goal is to improve provider adherence to guidelines. That is often the mandate in our projects. But adherence to guidelines is actually a complex set of behaviors. For example, adherence to case management guidelines involves multiple steps: screening patients for fever, conducting tests, providing ACTs, conducting differential diagnoses for patients who test negative for malaria, providing counseling, and so on. So that's at least 5 sub-behaviors, if not more. If, however, we map out these sub-behaviors related to adhering to guidelines, we can pinpoint where the biggest performance gaps are, or which behaviors providers are struggling with the most. And this will help us identify where best to intervene. On the right is a figure showing the results from my health facility assessment in Mozambique. Of 277 patients displaying malaria symptoms, only 94% were assessed for fever. Of those 94%, only 82% were tested. These were symptomatic cases, so basically everyone should have gotten tested, not 82%. So we can see here that the first major performance gap was malaria testing. Furthermore, nearly every patient got the right antimalarial, but only 70% of those patients were prescribed the right dose. So correct dosing is the major performance gap. And finally, only 59% of those who received antimalarials were correctly counseled. And that's a third performance gap. Based on this information, we can design a program that emphasizes 3 priority provider behaviors: malaria testing, appropriate dosing, and counseling. Next slide. So it's best to stick to 2 to 3 priority behaviors at a time. If one is trying to change too many behaviors at once, it can be hard for providers to retain content and sustain behavior change. Since we would ideally be focusing on the biggest performance gaps, these are also the areas with the biggest room for improvement and the biggest opportunity to demonstrate success. Once these performance gaps have been largely addressed, the program can move on to emphasize other behaviors. And it doesn't mean that the program has to ignore all aspects of clinical guidelines. It just means that most of the program's effort is spent emphasizing 2 to 3 practices during a set period. Mapping sub-behaviors can be done with health facility data, service provision assessments, or supportive supervision checklists, and to some extent, HMIS data. Next slide. The next best practice recommended in the blueprint is to identify specific groups of providers to target. Tailoring approaches to a specific group is better than trying to reach everyone with a generic approach. Different groups behave differently, and they respond differently to different interventions. One may wish to examine, for example, if the behavior is a bigger problem among doctors than among nurses or environmental health technicians. Similarly, it might be better to approach doctors in a certain way and midwives in another way. Customizing a program to the interests of different subgroups of providers increases the likelihood that the program will resonate with them more, leading to more effective and sustained behavior change. It can also lead to more efficient use of resources and a greater return on investment. Next slide. In the blueprint, we go over different ways to group providers and the pros and cons of each. The first row shows approaches that many of us are familiar with. Sometimes we target providers based on their cadre, like doctors versus nurses. Other times we choose to focus on people with certain roles, like OICs or officers in charge, or providers who work in the public sector versus providers who work in the private sector. Sometimes we use a combination of these approaches. Using this method of grouping is convenient. We can usually just ask the district to give us a list of people who meet our criteria. However, sometimes administrative data is incomplete or inaccurate. Many facilities may have providers on the roster who are actually not available for various reasons. Often the same people are getting access to all of the professional development opportunities. And this method of grouping providers assumes that those people all have the same beliefs and motivations. Another method for targeting providers is to focus on high volume facilities that are also low performing. This can be impactful because you're targeting providers with high caseloads who also have a lot of room for improvement. However, you would need data on performance and volume. Some of this can be obtained through the HMIS, and that can be a good way to go if the data is reliable. Another method is through supportive supervision data. We will see an example of that in a minute. Last but not least, it may be possible to group providers based on their attitudes, beliefs, and biases. This is an approach that has been applied to marketing and family planning. Data in the form of surveys and interviews is collected and then analyzed. Certain types of people who share certain attitudes and traits are then identified. This method requires even more data, as well as analytical skills. Every step or best practice recommended in the blueprint can be implemented using a range of easier, more convenient methods, as well as more intensive and more data-driven ones. The important thing is to be aware of your options and to make a deliberate decision on which one is best for your program at that time. So now I'll hand over to Mary, who will share a recent example of grouping providers.
Thanks, Angela. In this example, we'll look at how digital tools can help prioritize health facilities and resources. Outreach training and supportive supervision, or OTSS, is the foundation of many malaria quality assurance programs, and it provides on-the-job support to malaria service providers. The OTSS Plus package is a suite of malaria diagnosis, case management, and malaria and pregnancy checklists based on WHO guidelines and adapted to specific country protocols. Supervisors use the checklists when observing malaria service delivery in health facilities. The checklists are critical tools to assess the quality of services provided and provider adherence to clinical guidelines and standards. Rounds of OTSS Plus can be resource intense. They require careful coordination, staff time, transportation costs. They're typically conducted on fixed intervals across all facilities of a given type. But this assumes all facilities have the same need for support, as well as the same contribution to health impact. And as Angela just mentioned, targeting specific groups of providers, or in this case facilities, based on volume and ability can potentially lead to high impact. But this requires additional data and ways of looking at it. That's where digitizing the OTSS Plus checklist can help. A digital platform such as the Health Network Quality Improvement System, or HNQIS, can capture both fever case volume as well as quality performance scores from the checklist. The HNQIS platform can then automatically group facilities based on high caseload and low quality performance, flagging these facilities as needing more intense support. This can then help district supervisors prioritize resources, such as more frequent supervision visits or additional training, to those facilities that need them most, rather than using a one-size-fits-all approach across all the facilities. Of course, as Angela also pointed out, grouping facilities in this way assumes that providers within a facility all share the same beliefs, values, and motivation. Next, we'll hear about how to diagnose behavioral factors. Back to you, Angela.
Thanks, Mary. Next slide, please. Thanks. So the third best practice described in the blueprint is to diagnose the factors affecting behavior. We often focus on making sure providers have the commodities and skills to provide malaria services. While commodities and skills are absolutely vital, there is a growing recognition that there are other crucial factors that are often overlooked that also affect provider behavior and quality of care. Studies increasingly show that provider norms, beliefs, and attitudes can affect adherence to guidelines. On the left, Devlantes et al. Found that in Guinea, the strongest and most consistently predictive factor for correct malaria case management were provider norms, or providers' beliefs around typical, expected, and appropriate behavior. In the facilities where providers felt that correct case management behaviors were normal and expected among their colleagues, these facilities had substantially better case management practices. The other two quotes on the right are from the multi-country reviews. They have also found that factors other than knowledge, like preferences, priorities, and expectations, influence adherence to case management guidelines. Next slide. This model shows that provider behavior is influenced by many factors within and beyond the individual. Providers can be influenced by their own perceptions of themselves, their perceptions of malaria interventions, their interactions with client, what goes on at the facility or in the workplace, the community, the district, the national, and even international level. To identify the factors at play in one specific context, a program can start with a literature review and then move on to actually meeting with providers and asking them questions. Perhaps this can occur through a mentorship or supervision visit, or through convening focus groups and conducting key informant interviews. If time and resources allow, a research study can be designed. The process will vary depending on your institution and resources. The blueprint has an extensive literature review of factors found to influence IBTP, adherence to test results, and quality of reporting. For this reason, the blueprint is a great starting place for those who are planning to design programs or research studies, since a lot of this information is already synthesized for you. Next slide. Finally, after having found the factors that led to the performance gaps in the first place, we can now choose interventions that are specifically designed to address those factors. Again, the blueprint is a great resource for this. There's an extensive menu or list of provider behavior change interventions in the blueprint that one can refer to. The blueprint also summarizes what is known about what types of interventions work. It mainly draws from a recent systematic review, and I highly encourage you to look up this paper by Rowe et al. In brief, providing printed information or job aids alone is unlikely to be effective. Interactive, synergistic approaches tend to be more effective. In other words, combining group problem-solving approaches with training and supervisions are more likely to have larger effects. It is important to note that there is substantial variation in effect sizes among similar interventions, suggesting that the quality of implementation and context matters. And this is why the blueprint is useful, because if you can pinpoint the main performance gaps, prioritize the providers to work with, and identify the factors influencing the behavior, the greater the likelihood that you will have a strong understanding of the context and be able to design a quality intervention. Next slide. So this is just an excerpt listing the various types of interventions that operate at the provider and facility levels of the socio-ecological model. I will let you skim this list yourselves. And as you may recall, there are about 5 or 6 levels in the socio-ecological model, and there's a list of interventions for each of those levels in the rest of the blueprint. So now I'll hand it over to Mary, who will provide an example of diagnosing factors and matching interventions to those factors for malaria and pregnancy.
Thanks, Angela. So next we'll look at an example from Côte d'Ivoire. And I'd like to note that this intervention addressed malaria diagnosis, case management, and the prevention of malaria in pregnancy. But for the purpose of today's presentation, we'll focus on malaria in pregnancy, or MIP. In this case, Impact Malaria drew upon the findings from a broad situational analysis of health centers in Impact Malaria focused districts. The analysis was informed by interviews at the health centers, as well as routine supervisory and HMIS data. And the findings showed drug stockouts were an issue. And this was due to higher level supply chain issues, but also provider behaviors related to reordering stock and provider workload. When MIP drugs were available, providers often lacked cups or clean water to administer the dose, or they did not provide it because many women were fasting and the providers believed that it could not be given on an empty stomach, which it actually can. So you'll notice that the findings are a mix of access issues, behavioral factors, sub-behaviors, and they also span across multiple levels of the socioeconomic model that Angela shared. And this is quite normal and illustrates that provider behavior is definitely influenced by many factors. The intervention in this case here was supportive supervision using the quality checklists I discussed earlier. And the quality scores at the first visit served as a baseline for the intervention. And while the scores provided valuable information on adherence gaps to guidelines and protocols, they didn't always help to understand why providers weren't adhering to the service delivery guidelines. So a mentorship approach was layered onto the supportive supervision visits. And the mentorship applies a more consultative approach between the supervisor and provider. And feedback is delivered immediately following the observed malaria service and can be tailored to uncover and address the individual provider's behavioral factors. And during the 3 months of the implementation of this intervention, supervisors visited facilities twice and worked with the same providers wherever possible for continuity. And the results were promising, showing improvement in quality scores of 20% between the first and last visit. So this suggests that mentorship could be a valuable addition to the OTSS plus approach to supportive supervision, particularly if it's targeted to lower performing facilities that we spoke about earlier when we try to group facilities around their ability. Angela will now share another example. Over to you, Angela.
Thanks, Mary. So in this next slide, we have a case management example from Nigeria. The main difference between this example and the one that Mary just shared is that in Mary's malaria pregnancy example, the understanding the behavior and the factors were occurring in a more combined process between mentorship and like the situational analysis. In this situation, the process was more separated through observations. First, we conducted observations and key informant interviews. And through that process, we learned that in many facilities, the process of conducting RDTs and prescribing treatment can be convoluted and full of hassles for providers. So first, the client has to wait in line to see a clinician. Then the clinician decides whether the client should get a test. Then the client goes to the lab and waits in line again to get a test. They get the test done, they return to the clinician or the outpatient area, and then wait in line again to get a diagnosis and then a prescription. For this reason, many clinicians chose to just prescribe antimalarials from the beginning so they can clear their backlog of patients. Based on that finding, the resulting intervention sought to streamline the process. So now everyone who comes to the facility with a history of fever is automatically tested by outpatient or lab staff before they see the clinician. That way the clinician does not have to see the patient twice nor wait to get test results. The behavioral factor identified was the facility process, so the intervention was a revised process. We also learned that there were many misconceptions and negative attitudes towards RDTs and malaria. For example, providers felt that malaria was endemic, so negative RDTs must be unreliable. In actuality, malaria prevalence had been decreasing, so that assumption was no longer valid. So another component of the intervention package included clinical meetings or group discussions. We brought all the providers in a facility together to discuss these misconceptions and to develop a shared expectation or shared norms and understanding that RDTs are reliable and should be trusted. Next slide. So the next best practice in the blueprint is to involve providers in design. Our field in general tries to be very inclusive. We are good at involving stakeholders, particularly those at the national, province, and district levels in program design. Many of these stakeholders are former providers themselves and have implementation experience, so they have valuable perspectives to offer. At the same time, the blueprint invites us to take it further and to think more intentionally about involving current practicing providers in the design process. Involving providers is not an all or nothing activity. As the figure shows, provider involvement can take varying degrees. On the far left, it can be informative. We can collect data from providers, but the program makes all of the design decisions. On the far right, it can be deeply participatory. Providers can be involved in generating ideas and testing them out, very similar to the human-centered design process. And in the middle, it can be consultative, where the program proposes solutions and the providers gives feedback. Involving providers in design is beneficial for two reasons. When one involves providers in a more meaningful way, you will get a better understanding of the context. You will also increase provider ownership and satisfaction with the intervention and improve the likelihood that the intervention will be effective. How participatory you can be will probably depend on how much flexibility there is in designing the intervention. Sometimes the intervention has already been decided ahead of time, so you can only do a consultative or informative route to fine-tune it. Other times, the donor or program is more flexible, and you can use a more human-centered approach. So now I'll turn this over to Keith so he can share an example from Sierra Leone.
Thanks, Angela. So referring back to that last slide, this activity, which was conducted to improve usability and acceptability of the OTSS checklists in the Sierra Leonean context, IM took a consultative approach, which falls in the middle of that spectrum that Angela showed between a more and less participatory approaches. So IMHQ has created and adapted a series of gold standard checklists. Each country platform then takes those checklists and adapts them further to fit their own context. Generally speaking, the teams work with NMCPs to finalize these checklists, but in Sierra Leone, Impact Malaria took great care to take these checklists to members, to district DHMTs and other individual, in order to conduct the checklist review. So in fact, what we did is we went out to the districts and then further into the health facilities. So after review with DHMTs, IM members travel to health facilities to test the tool and gain valuable insights from providers. Feedback from both the providers and the DHMT members was then incorporated into the checklists. This collaboration yielded some great results. So for example, severe malaria management varies by facility type. So while we expected that a certain level of facility at the community health center would be treating severe malaria and its complications, as the guidelines state, we learned that this was only partially true. In fact, some CHCs gave pre-referral treatment and then referred on to higher levels of care. So this affected which types of checklists we plan to administer in the CHC. So additionally, we learned that the term complicated malaria was not often used in the public sector, and severe malaria was preferred. And so while we felt like distinguishing these terms was important, in the absence of further training and conversations with the NMCPs and others, this distinction would actually just be confusing. So finally, we also just learned something smaller. In the conversation with the healthcare providers, we really kind of disentangled the cotters of healthcare providers that we would likely see in the OTSS Plus visits. And so that was something that we clarified as well. So to recap, incorporating stakeholders into the checklist adaptation process increased ownership of the DHMTs and providers, which led to increased buy-in. As well, working with the stakeholders made the checklists and resulting data more clear, usable, and valued. Thank you. Next slide.
Great, thank you, Keith. Finally, the last step in the blueprint is to use holistic approaches to monitoring and evaluation. Although service statistics are important, they may not provide a complete picture of how well the program is doing. Sometimes the quality of the data is not good, or behavior takes a while to change. Monitoring changes in provider perceptions and attitudes, and assessing provider and client satisfaction can provide early indications that the program is having an effect. As mentioned earlier, context has been shown to be a determinant of how effective an intervention can be. Documenting how the intervention was actually implemented and how it evolved over time, or how it was tailored to different settings, will greatly improve our understanding of which provider behavior change interventions are effective and where they can be replicated. In the blueprint, we give examples of different data sources, their pros and cons, and where to find indicators. Next slide. So I'd like to invite you to think back to the Nigeria example earlier. In that example, an intervention package was developed that included simplifying facility processes, provider, and the use of provider group discussions, and several other components. This set of interventions were piloted in a small number of facilities for 3 months. To assess which components of the package should be continued and scaled up, we used a variety of data sources: lessons learned meetings, which are like focus group discussions, HMIS, a review of HMIS and lab registered data, client exit interviews, and provider surveys. As a result of using these multiple data sources, we learned which designs were feasible, aka which designs were feasible for facilities to implement. We also observed improvements in adherence to case management guidelines. We were able to explain why the improvement occurred because we could document changes in provider attitudes, and we received feedback on areas of the intervention package that seemed to work well. Finally, we were able to understand which parts of the package were confusing or needed to be tweaked, and which parts are better suited to different types of facilities. So the graph below just shows an example of provider survey data on provider attitudes and misconceptions. Next slide. So in conclusion, improving malaria service delivery requires lasting behavior change from providers. The blueprint can help us avoid automatically resorting to one-size-fits-all approaches by encouraging us to fully understand the context and lived experience of providers, while also respecting and keeping clinical guidelines and standards in mind. Although it would be ideal to practice every step in the blueprint to the fullest degree throughout program design, even partially adopting or practicing some of these steps can be beneficial. We should not let perfectionism get in the way of applying the best practices described in the blueprint. Most, if not all of us, are already doing them to some degree. Every best practice in the blueprint can be implemented using easier, convenient methods, as well as more intensive and data-driven ones. The important thing is to be aware of one's options as one embarks on practicing each step, so one can make an informed decision on which methods will help you practically achieve your program's goals. Thank you.
Great, thank you so much, Angela, Mary, and Keith. That was a great introduction to the key elements of the blueprint and the different ways to practically apply it to improving service provider behaviors. So at this point now, we're going to transition to the question and answer, and we've received tons of great questions in the chat box. So thank you very much and keep them going. And we'll try to get through as many as we can in the remaining time. And the first question that we're going to put to the presenters is, how do we approach service provider behaviors when important determinants or factors that are influencing those behaviors are really beyond their individual control? So this might be related to outpatient burden, changing in specific days or seasons, if there's a lack of certain commodities like diagnostic materials, RDTs, job aids aren't available, or different kinds of logistics for case management.
Should I take that one, or does someone else want to take it?
Angela, maybe you can get us started, and if Mary or Keith want to add on.
Okay. I think that's a great question, and it's usually the starting point for where we usually design programs. You know, access to commodities is definitely one of those factors that influence behaviors. So it's really important to kind of tease out when there's an access problem and when there's a behavioral problem. Access problems can be fixed with access type of interventions like improving the supply chain. Also, it should be kept in mind that some access problems have a behavioral root cause. For example, like if providers are not turning in their logistics requests or reports and requisitions forms in time. So that can lead to delays in supplying facilities. In terms of other factors like lack of diagnostic materials or job aids, a lot of the time providers may not even look at job aids for very long. They might refer to it and then put it away. There's not a very strong, clear relationship between the use of job aids and sustained performance. So again, it's important to tease out like what are the reasons for why providers are not using these job aids, or what are the reasons for why they're continuing to practice the way they're practicing and not referring to these job aids. So we need to dig deeper into some of these issues.
Yeah, thanks, Angela. And I think that's one of the nice elements of the blueprint as well, is that it doesn't take just that individual provider behavior lens, and it looks a little bit more holistically at the different ecological and kind of systemic issues, such as supply chain, for example, in considering how to change behaviors.
Mm-hmm. Exactly. I would just add that is a perfect question that highlights the socioeconomic model that Angela spoke about, and it highlights that we need to take into consideration all of those factors, and many of them are beyond the provider's control. So I think that question very much highlights some of the key principles in the blueprint.
Great. Okay, thanks. So we're going to move to the next question, and this question's interesting. It was asking, how do the results of training and supervision of providers in malaria service delivery compare with performance-based programs? So like performance-based financing, et cetera. So how do we kind of how do we compare those two in terms of what's effective in encouraging good provider behaviors?
Hi, this is Mary. I think that is a very good question. You know, I'm not sure that we know the answer to that. Impact Malaria will be looking more closely at OTSS Plus and the results of training and supportive supervision, and in particular, the supportive supervision approach, because it is a widely accepted and acknowledged a tool for improving quality of services. But, you know, we do need to take a closer look and really document what that improvement looks like and how it does compare to other performance-based programs. I'm not sure if that's been looked at. And, you know, Impact Malaria is also working on a learning agenda around malaria service delivery, and we'll soon be talking about quality improvement, and I'm actually going to take this question to that group as well to discuss more and dive in a little bit more deeply into that. So I don't know if Keith has anything else to add, but if we don't have the answer to that, I would say watch this space, and we might have something in future to share.
Yeah, thank you, Mary. I would kind of just echo what you said. I think this is a question that we're very interested in looking at in great detail, to really be able to talk in specifics about how and why OTSS plus is a strong approach, or what other approaches are strong. So again, this is something that our team is talking about, and yes, watch this space.
Great, thanks guys. So a great question, and then a kind of a stay tuned response. Hopefully maybe there'll be a future webinar addressing that topic. So one of the next questions we had was a request to explain a little bit more about how the OTSS checklists were validated, and how we can consider them the gold standard.
Yeah, I'm happy to take this, and thank you for that question. And I think I'll answer it in a couple of ways. First of all, I guess gold standard could potentially be subjective when used in this form, talking about checklists. But these checklists that were developed at HQ are actually adaptations of some checklists that were developed in previous PMI projects, IMAD, Malaria Care. And so they're kind of a continuation of these sorts of checklists that have been kind of reviewed, updated, adapted, reviewed, updated, and adapted, and have run through PMI over the last, actually over 10 years. We also have some, for instance, MIP checklists that have been brought in through other projects, including PMI projects, MCSP, et cetera, that we're using as well. So to say that they're gold standard may not be 100% accurate, because I think that might be subjective when we're talking about supportive supervision checklists. However, these are the checklists that have been used throughout the years. And I will just say one more thing. Impact Malaria is currently working on an activity in collaboration with the WHO to actually look at supportive supervision checklists, almost going back to the last question that was asked, to think about what type of checklists and what sort of quality assurance approaches would be most effective and are most effective. And the end product of that is likely going to be a set of checklists that have been validated through the WHO. So that's an activity that Impact Malaria and WHO are working on this fiscal year, continuing into next fiscal year. So that's also, sorry to kind of give you another watch this space answer, but I think that that's also something that's exciting that we're really looking forward to having.
Great, thanks so much, Keith. So the next question we got here was, how do the results of the provider behavior improvement initiatives affect the uptake of malaria services with the very poor? So health providers' behavior can sometimes put off the most vulnerable populations from attending health facilities. And then there was another question in here that I think maybe we could put together with this, was about user fees, and how do user fees affect provider behavior? And so even though RDTs and ACTs might be free for children under 5, there can be other implications when it comes to income generation. Maybe that's a lot to put into one, but maybe thinking first about how provider behavior can impact those who are most vulnerable in terms of the quality of their interaction.
Thank you. That's another great question. And, I think that the blueprint really helps designers of interventions look at such issues, because sometimes they are overlooked. So this is a really nice, deep question that I think in designing an intervention, if that's something that's coming out, it's looking at the provider and client dyad there and that interaction. And so, and also thinking about pre-service, like what it is that gets that client into the facility to receive care. And it kind of combines both the the target audience or consumer and provider behavior change to try to find out what the clients are thinking and why they're not going, and then take that information as well to try to do some training and support to providers to change their attitudes or behaviors around whatever might be the blockages in that client interaction. To improve that so that clients feel more more comfortable going to see that client. In other areas, you can also do, if there are some attitudes or beliefs around certain segments of the population, you can do values clarifications to really help providers understand what those are and see those, and then develop your interventions around supporting providers to break out of those beliefs and attitudes. I think I may have forgotten the second question.
Yeah, that's okay. No, thanks, Mary. That was great. Yeah, I think that's a really important point in terms of how providers treat clients, or how clients treat that or perceive that they're being treated, and the really important role of that intersection between service delivery and social and behavior change. I think is a really important space that is people are paying a lot more attention to now. So the second part of that question was going in a slightly different direction, but about user fees. And so how do user fees affect provider behavior? And though, RDTs and treatments, ACTs, are free, sometimes providers can prescribe other treatments that might not be free. Microscopy isn't always free. And then this can really have an impact on client or patient care-seeking behaviors, and whether or not people come back to the health facility, depending upon what they're asked to pay for when they're there. So I'm not sure if any of the presenters have some direct experience or perspectives on how to approach that challenge of user fees, which is quite complicated.
Yeah, this is Angela. Yeah, it's definitely, I don't think that, I can personally speak to, personal knowledge about or evidence on the effectiveness of these user fees. But I do want to highlight that the blueprint kind of provides menus or lists different types of interventions that can be used for different levels of factors. So again, going to that intersection between the provider and the client, and how the provider's behavior affects the client uptake of services, there are a number of interventions described in the blueprint where what that could be used to improve that relationship between the provider and the community, or the provider and the client. And this issue of user fees can be complex because a lot of these are cost recovery mechanisms, and facilities will not be able to operate without some level of fee collection. So it's a complex issues, but I do know that there are some programs that have looked at, for example, negotiating fees between communities and providers to kind of identify and agree on what is acceptable.
Thanks very much, Angela. Yeah, and that's a real dynamic space too, as certain countries transition to maybe more of a universal healthcare model. So definitely something very relevant and complex, and perhaps something we could address in a future venue. So thanks for that question in response. The next question relates to community health workers. So are community health workers included in the research and sort of the lens that this blueprint takes as frontline providers in diagnosis and treatment?
So I'll start off. So we mainly looked at it through the lens of facility-based providers. However, a lot of the sort of the main steps are still likely applicable to community-based health workers.
Yeah, thanks, Angela. And that probably ties in really well to that targeting of the health worker type, and what some of the different determinants or factors might be relevant for community health workers might be quite different for facility-based providers. Great. So another question is a little bit more timely now. So given the current context of the COVID-19 pandemic, how would this initiative be implemented or rolled out, as we're not really sure how the whole COVID situation is going to evolve, or how it's going to endure, and how it's going to impact service delivery in different ways in terms of supply chain or care seeking. So don't know if the presenters have given some thought to that, or how they're adapting interventions on the ground in the countries where they support programs.
So this is Angela again. There are a couple of programs that are adapting to the COVID context. I've heard of at least 2 projects that are moving to more of a virtual mentorship as opposed to in-person mentorship approach. So, I mean, we'll stay tuned and see how that could play out, but so it depends again on how they do virtual mentorship. Like some providers may benefit from more personalized phone calls as opposed to, you know, blanket WhatsApp messaging to, say, a WhatsApp group, or but may also benefit more from an in-person visit. So it's hard to know exactly how effective it can be, but at least it's a way of sustaining our contacts with provider and providing them with some sort of support and cues to continue practicing the behaviors we want them to practice.
Yeah, Angela is correct. It's quite amazing. Many of the countries are embracing virtual applications, even Zoom meetings, to do face-to-face interactions with providers for supportive supervision, and telephone calls, and talking to providers, and the mentorship can continue. So I mean, we're really fortunate that we have technology that can be used in so many of our countries now. And in addition, Impact Malaria has been working to help you know, adjust checklists and training for differential fever diagnosis as well, so that it's including symptoms of COVID that then could be, and this is with separate COVID funding than from our PMI funding, but that then those providers then can refer suspected cases to other facilities or other providers for actual treatment. We are also you know, making sure that facilities are clean. And I think a lot of this is to Impact Malaria works on the provider side, but it's really also finding out on the client side if they're not going to clinics, and what that might be, and how to reassure them, or what the issues are then on the provider side with the clinics, you know, if they're safe, if they are doing proper infection control protocols, et cetera. And so Impact Malaria with separate COVID funding in a couple of countries where we've received that has also been trying to help with you know, clarifying what those procedures are and what those guidelines are. And we're working on trainings to be delivered virtually at virtual platforms. If we can't bring folks together for traditional trainings, as we've done in the past. And, you know, even in those cases where that's not possible, we have been able to train providers by making sure that we have no more than 10 providers in a room. They're 6 feet apart at their desk. Everyone is wearing masks. There's hand sanitizer, et cetera. So it's pretty amazing how everyone's been adapting, because you know, we can't stop malaria service delivery. You know, more people will die from malaria, you know, if we do. So it's just been amazing to see that response, and that creativity and that innovation of how to continue supporting providers and supporting malaria service delivery in this context.
Great, thanks. Yeah, it's really incredible to learn about the adaptations that are happening in the field. And maybe just a quick follow-up, Mary or anyone else, how are you going about sort of monitoring for those changes, and when those adaptations really need to be sort of intensified. So in terms of care seeking or provision of services like testing, are you able to get a good feel for how that's evolving in the countries and the regions that you support?
In relation to COVID?
Yeah, in relation to
Yeah.
COVID, in terms of the impacts that I know it's, you know, there's a lot of anecdotal information, but really trying to sort of quantify and qualify that, I feel like has been a real challenge for people.
You know, everything is happening so quickly on the ground that you're right. Like a lot of the information that we're getting is anecdotal, but like I mentioned, it's really incredible that so many of our activities are still able to continue. There are, of course, huge challenges with our DTs in this environment, where some of the manufacturers are shifting their attention to COVID testing rather than producing COVID tests, rather than producing RDTs. So that's certainly a challenge. There are challenges with supply chain where maybe not this year, but next year, looking at the drugs used for SMC campaigns. We have drugs this year, but you know we need a lot of drugs for SMC campaigns. In fact, malaria alone reaches over 3 million children each year with SMC. So you know we follow the national guidelines in terms of safety protocols, et cetera, and social distancing is what's coming out of the governments in the countries that we work with, and we're trying to monitor what the uptake is and if people are coming to clinics. So I don't have any hard answers for you right now, but from what I can see is that you know, services are still being delivered, and we need to wait to see as we get deeper into this what those results are. There's certain lag time with getting the data to us. So, but yeah, that's a good question.
Yeah, it was a hard question. Thank you for the response. I know it's certainly dynamic. We have a lot more questions, great questions from all of the participants, but we have unfortunately come to the end of the hour. So I want to thank all the presenters. We definitely could have devoted an entire webinar to each topic and spent some more time discussing all of these great questions. But so before some closing remarks, I just wanted to give you guys a reminder to please take a minute to answer those 4 poll questions before you sign off. We'd really appreciate it. And I'd really like to thank Angela, Mary, and Keith for their excellent and thought-provoking presentations today, and to all of you who dialed in from all over the world to join us and for your great questions. So to recap the important themes discussed today, improving provider behavior is essential to achieving our goals in malaria. Provider behavior is complex, as we all know, can be driven by factors beyond just knowledge and access to commodities. But by bringing together insights from behavioral science as well as clinical expertise, we can develop programs that more effectively support providers to have positive interactions with their patients, to provide high quality case management and preventive services, and to improve the quality of routine data. And the result of this will be fewer malaria cases and deaths, healthier communities, and a stronger health system. So we encourage you all to download the blueprint, refer to the other resources that are listed on the slide here. And we're also pasting a link to the blueprint in the chat box below. The blueprint is also available in French. There were a couple questions in the chat box about the resources being available in French. So they are. Please share them with your Francophone colleagues. And if you have additional questions, you can reach out to any of the presenters. Their contact information can also be found in the slides. We will send an email with the recording and the slides from today's webinar. So again, thank you so much for attending and hope everybody has a wonderful day and evening.